keynote speaker tonight is Dr. Diane Meier, MD. She's a geriatrician and a palliative care specialist, and she's director of the Centre to Advance Palliative Care in New York, which is a national organisation dedicated to increasing the number and quality of palliative care programs in the United States. She's also Vice Chair for Public Policy, Professor of Geriatrics and Palliative Medicine, and Catherine Gaisman Professor of Medical Ethics at Mount Sinai Hospital in New York City. And she was the founder and director of the Hertzberg Palliative Care Institute there nearly 20 years ago. Dr. Meier is no slouch in the media either. She's much called upon expert in national and public and private TV and commercial TV and radio and in the press, and just yesterday she wowed them all on John Fane 774. So please join me in welcoming our keynote speaker tonight, Professor Diane Meier.
Oh my goodness. Well, good evening, everyone. It's such a privilege and honor to be with you. I'm very grateful to have been invited to give the inaugural lecture, public lecture. I have never spoken in such a beautiful architectural space in all my many years of public and professional speaking. And I've spent the last 3.5 weeks traveling around a small bit of your exquisitely beautiful country and getting to know some of your really wonderful fellow citizens. So thank you for that. Also, as I'm listening to Simon, I'm thinking he has said it all. Maybe I feel like I should just sit down, but they did pay my way over here. So, what he said. But I'll begin by saying what Simon said and adding a little bit to it, really reinforcing what Gail said. What is palliative care? Palliative care is a relatively recent and growing medical field that is focused on maximizing quality of life during serious illness. It has nothing to do with prognosis. It has only to do with need. So it's about addressing the pain, the other symptoms, the stresses, the family exhaustion and needs, and helping people have the best life possible for as long as they have. And I begin with this photograph here of a young woman named Christina. And we know Christina because she was actually a registrar in medicine at Mount Sinai's training program. And this is a photograph of her on one of her rotations learning how to do house calls. One thing I'm proud to say is that all of our registrars do house calls for a month before they finish their training. And here she is with very long, beautiful hair doing a house call. At the end of her registrar training period, 3 years, she had her first baby. 2 weeks after the child was born, she began having difficulty breathing. And it got worse and worse, and she had a chest x-ray, and they found a large mass in her chest. She's probably 28 years old with a newborn baby at home. And so she went to the highly specialized, superb cancer hospital in New York City, where they made the diagnosis and offered her appropriately aggressive curative treatment for her lymphoma, which can be cured in some cases. And as she was sitting and talking to the oncologist who was going to treat her, she said, "Well, I assume that you provide palliative care as part of the cancer treatment." And he looked at her like this, and he said, "You don't need palliative care. You're not dying." Right? This is a doctor, a recently trained doctor at a major cancer hospital in New York City. But Christina had trained at a hospital with very well-integrated palliative medicine and palliative care. She had worked alongside palliative care teams in the care of her patients, many of whom were seeking cure. others of whom were seeking to live a lot longer with whatever they might have, some of whom had progressive, serious terminal illness. But she knew what palliative care could do, and she was damned if she was going to go through this treatment without it. But she couldn't get it at the cancer hospital because they thought palliative care was just for the people for whom there was nothing more that could be done. So, but Christina is an informed consumer. She's a doctor. So she went to the palliative care program at Mount Sinai, and she was co-managed from the outset of her illness through until she is now, for all intents and purposes, cured. And she speaks so eloquently about how she could not have gotten through this. Imagine this: chemotherapy, radiation, newborn baby at home that she can't hold because of the treatment. Tremendous symptom distress, not so much from the lymphoma, but from the aggressiveness and intensity of the chemo and the radiation. She couldn't sleep, she was nauseated, she was profoundly fatigued. The fatigue was the worst part, she said. All of those things were managed concurrently by a palliative care team at our hospital while she got the best cancer care possible at the cancer hospital. She would say she's not sure she could have gotten through it, the treatment, without access to palliative care at the same time as cancer treatment. So when you think about palliative care, think about Christina. God willing, she's cured. God willing, she will live to see her child grow up and get married. But that very difficult disease that she went through and the treatment that it required was made bearable by concurrent palliative care. So why was Christina able to get that? Because she knew what palliative care was and she insisted. Had she just done what the doctor said, she would not have gotten it. She was an informed consumer, and she said, "You're wrong about palliative care. I'm not going through this without that." So my message to you as the informed consumer is key. You will get the care you need if you know what you need and you demand it. And if you just kind of go with the flow, you may not, because just like Christina's oncologist, most doctors in Australia, as in the United States, think that palliative care is only for the dying. So you, the public, need to be informed and educate your clinicians in that regard. Christina came and spoke with us in front of a congressional briefing in Washington to articulate the crucial importance of access to palliative care during curative treatment for serious illness. So let me tell you about another patient. Why is it that Christina's doctor didn't understand that palliative care is appropriate at any stage and in any type of serious illness? Is it because he was indifferent, callous, uncaring? Is it because he got paid more for giving chemotherapy than comforting people? The answer to those questions are no. It's because he didn't know, because his training did not include an understanding of what palliative care involves. And this is another patient I took care of that I published the story of Jenny in Health Affairs, which is a US health policy journal. The title of the article is, "I Don't Want Jenny to Think I'm Abandoning Her." And we'll come back to that in a minute. This is Jenny. When I met her, she was probably 57. She was a full-time clinical psychologist. She had been diagnosed 4 or 5 years earlier with lung cancer. So she had already far outlived the prediction. They told her she'd be dead within a year. 5 years later, here she was, working full-time, looking like this. And what was happening is that there were starting to be shorter cycles of responsiveness to her with her cancer. And she kept asking her oncologist, "What's going to happen if this doesn't work? What does the future hold?" And he would say, "Oh, we don't have to worry about that, Jenny. I have lots more tricks up my sleeve." Now, Jenny was a clinical psychologist, and she knew that what was going on is that he, the oncologist, could not face talking to her about what the future might hold. It was his pain and distress at the possibility that at some point this treatment would stop working that prevented him from talking to her, answering the questions she wanted to have answered. And so she, an informed consumer, went on the internet and Googled and found me, because I'm also in New York City, and called and made an appointment and came to see me probably 2 months later in my geriatrics practice. So here's this young, gorgeous blonde woman coming into this practice with a whole bunch of people who look very different than she did. This is her husband and her daughter, Sarah. And what she said, and she looked great, and she was functioning fine. She said she wanted to know what would happen when the treatment stopped working, even though it was still working. And she said she was having trouble enjoying her days because of the fear of the unknown, because of not knowing what it would be like to die, because of not knowing who would take care of her, of not knowing how her husband and daughter would manage. The fear of the unknown was stealing her pleasure in life and her quality of life. All this additional time her oncologist was giving her was being consumed with fear and anxiety. So she and her husband came in and they said, what's it like to die? And I asked them, do you want to know what the normal process of dying is? I'd be happy to tell you about it. So I told them. So you get weaker and weaker, you get sleepier and sleepier, you have less and less time of alertness. During periods of alertness, you may be completely lucid and yourself. If you have symptoms, pain, shortness of breath, anything, those can be treated. And then you get deeper and deeper into a deep sleep and then eventually a coma where you're not responsive anymore. You can probably hear people's voices during that time, but may be unable to respond. And that can go on for several days. And then breathing gets very rapid. And then breathing becomes irregular so that there are pauses in between breaths. And that can go on for 24 hours. It can be very hard for families to witness that and be the vigil at the bedside to that. And then during one of those pauses, you will die. And 90% of the time, it's very peaceful, very comfortable, very much within the human compass experience. And I could see the anxiety on her face and in her shoulders go away. Because her imagining of what things would be like was 1,000 times worse than the reality. And you can understand that. She thinks, my doctor won't even talk to me about this. It must be because it's too horrible to talk about. And if you watch TV or, look at magazines, death is the huge fear. But, as in the title of this talk, so far, it's one for everybody. One birth, one death. And nature has a lot of wisdom. And the dying process is something that humans can go through, can witness, can care for one another during, and she just needed to understand that. And she went on to live another 3 years with me managing fatigue, depression, pain, memory issues, and her oncologist trying one new thing after another and prolonging her life very significantly. So just like Christina, she got both cancer care and palliative care for the next 3 years. So why am I telling you this story? So at a certain point, she had metastases in her brain and started having difficulty concentrating and remembering what her patients were telling her. And she went to see the oncologist and said, what can we do about this? I'm going to have to stop working if I can't remember things. And he offered something that the clinicians in the audience will recognize called intrathecal chemotherapy, which is it's brain surgery. It's putting a catheter into the tumor in the brain and infusing chemotherapy directly into the tumor. And Jenny took that in, and then she called me. She left his office and she called me and she said, Dr. C recommended intrathecal chemotherapy. What do you think? So my gut reaction was, is he out of his mind? But I didn't say that. I controlled myself. And I said, you know, Jenny, this is not my area of expertise. Let me call him and ask what he's hoping we can accomplish with this treatment. And one of us will get back to you. So I called Dr. C, and I said, you know, Jenny called me today after she saw you, and she mentioned that you had recommended intrathecal chemotherapy. I'm not really familiar with that treatment for brain mets. What are you hoping we can accomplish with this treatment? Without a second's pause, he said, it won't help her. So then I had to pause again and control myself, not to say something inappropriate. So there was a pause, and then remembering that I was the consultant and he was the treating physician, therefore my job is not to tell him what to do, his job is to tell me what to do, really. I said, do you want me to encourage her to go ahead with it anyway? And then there was a very long and awkward pause on the phone where neither of us said anything. I mean, it was probably 3 seconds, but it felt interminable. And he said, I don't want Jenny to think I'm abandoning her. This was one of the most profound teaching moments of my life to date, because I spent so many years trying to understand why my colleagues did things that made absolutely no sense, that actually did more harm than good, that might even shorten people's lives, would certainly worsen the quality of life. Why were they recommending things they knew were not going to help? And Dr. C taught me why. Because he loved Jenny and was totally committed to her and had worked incredibly hard and effectively for so many years to give her really good time, way more than she had any right to expect. And he couldn't bear to say, I can't fix this. And so all he knew how to offer was more treatment, because that's all he was trained to do. He wasn't trained to talk to Jenny about what would happen when treatment stopped working. He wasn't trained to help her understand what death would be like and to walk with her when she had to come up to that, to not abandon her at that time. It wasn't part of his oncology training. So he did the only thing he was trained to do, offer more treatment. That is not his failure. That is a failure of medical education. And it is a profound failure, and it crosses the globe. We train very highly specialized people to do things to people, and that's all we train them in. Australia is ahead of the rest of the world in this regard, and congratulations to you. You have amazing leadership here. But for the most part, we train doctors to try to cure, to try to prolong life, and we don't really give them any other skills. And the New Yorker had a cartoon right at the same time that I love, so I'm going to show it to you. It's a doctor saying to a patient, there's no easy way I can tell you this, so I'm sending you to someone who can. Those of us in palliative medicine think that's a really good doctor, because he knows the patient needs the information, but he doesn't know how to do it. So he's going to send his patient to a palliative care specialist who knows how to communicate. But that's ridiculous. Every doctor should know how to have these conversations, right? This is a core competency for medicine, right? So the training issue is really critical. And had Christina's doctor understood that palliative care helps people get through treatment, had Jenny's doctor understood that palliative care will help the doctor and the patient walk all the way through the illness together, they might not have had to fend for themselves the way those two patients both had to. And now I have spent a lot of time talking to you about relatively young people with cancer. And while young people with cancer get a lot of press and have extremely difficult and challenging experiences, the great majority of us do not die of cancer. 78% of us do not die of cancer. Most will reach old age. Average age of death is in the late 70s, early 80s now. And most of the period before death will be accompanied by arthritis, memory loss, frailty, heart problems, lung problems, kidney problems that don't kill you for a very long time, but that you live with for a very long time, and that your family lives with for a very long time. Yet, palliative care is not thought of as appropriate for those 78% of us, because those 78% are not yet dying. Yet the burden of illness, both on the patient and the family, is intense. So this is an example of a patient who is still alive 2 years later, whom I met 2 years ago in the emergency department, where he was for severe low back pain from severe arthritis that caused such a bad back spasm that he couldn't get up. And it was after office hours, so when his wife called their GP, she got a tape that said, if this is a medical emergency, hang up now and call, in our country, it's 911 for emergency. And so he was brought to the emergency department of my hospital, where, as it turns out, this was his 4th emergency visit in a 3-month period for similar issues: back pain, constipation with confusion, and a fall. And those 3 prior emergency visits, he was hospitalized and gotten all kinds of trouble in the hospital. Infections, falls, developed incontinence, got confused. None of those things would have happened if he was home. But they happened because he really didn't belong in the hospital. It wasn't the right place for him. And the emergency room doc who called us down there said, I don't know if this patient's appropriate for palliative care because he's not dying. And I'm thinking, even in my own place, I can't get this message across that palliative care is not just for the dying. But this couple is abusing the emergency room for low back pain. That was the language. We blame the patient for the system that we designed, for the system design failures that we tolerate, not the patient's fault. In any case, what we were able to do was get his pain managed with very, very small doses of opioids, get him on an appropriate bowel regimen, because opioids are very constipating, and that's the major risk of those drugs. Get some support in for his exhausted, overwhelmed wife. Get Meals on Wheels delivered, because she couldn't go grocery shopping because he couldn't walk because of the back pain, and he would freak out if she left. And connected them to a friendly visitor program through their church so that there was less social isolation. She got a chance to get out of the house, and that church actually started sending a car to pick them up on Sundays, to take them to services, give them lunch, and take them home. That was 2 years ago. He has not once been back to the emergency department or the hospital. Now, if he had continued going to the hospital, he would certainly be dead by now. Just the consequences of hospitalization in frail older people. Hospitals are dangerous. Infection risk, all kinds of problems. Now he's home, he's getting much better care and much better support at dramatically lower cost, because he's not going back and forth to the hospital all the time. But he was lucky, right? The system wasn't designed to get him that kind of care. He was lucky that the emergency room doctor had been a medical student at Mount Sinai and had rotated on palliative care and knew that, as he said, you guys perform miracles. So because he happened to have an emergency room doc who had had exposure to palliative care, and I happened to be carrying the beeper that night, he got appropriate care. But it wasn't the glide path. It wasn't standard of care. It was the exception. So our challenge as advanced societies is to make that care the standard and make these repeated visits to the emergency department for problems that should be managed in the community the exception, or even the never event. And I think if you think about Christina and you think about Jenny and you think about Simon's son, you will start to see that actually not only does palliative care not kill people, palliative care in now an accumulating group of studies prolongs life. And this was a trial published in the New England Journal of Medicine a few years ago that compared lung cancer patients getting best cancer care to lung cancer patients getting best cancer care plus palliative care in the cancer center from the point of diagnosis. And no surprise, the people who got both, the concurrent care, had better quality of life, less depression, families did better, they were less likely to be hospitalized at the end, they were less likely to get chemotherapy at the end, but to everyone's shock and surprise, the palliative care group lived 3 months longer than the usual care group. I had colleagues at Mount Sinai who called me when this paper came out and said, "That can't be true. We know palliative care kills people." It doesn't. It prolongs life. I wonder if anybody here in the audience, so there are 5 or 6 studies suggesting that palliative care prolongs life. There are no studies suggesting that palliative care shortens life. None. Okay. So much for data. Opinions withstand data. So let me ask you, members of the public, not clinicians, why might palliative care lead to a longer life? Any ideas? Dignity, like feeling like you have a reason to go on. Stress reduction. So we know that, for example, depression is a major driver of death and mortality in all diseases. So is stress, because it is stress is immunosuppressive and reduces your resistance. What else? Good pain control. Why would good pain control help you live longer? Yeah. Yeah. Good pain control, as Simon described about his son, good pain control, lucid and functional. No pain control, terrible, devastating. But you guys haven't mentioned probably the most powerful reason for life prolongation. Sorry? Optimism, yep. Feeling like it's worth it to stay alive, that life is worth having. You're not terrified and you're not suffering. But, perhaps I'm jaundiced, but I think a major reason is that they were much less likely to be hospitalized. And we know that hospitals carry major risk of infection and other adverse effects when you are a vulnerable person, like Mr. B, like a cancer patient who is immunosuppressed and really can't fight an infection. So staying out of hospitals is better for you if you can. I think it's all the things you mentioned, not being an extremist, not being afraid, knowing what to expect, having your symptoms controlled. So how do we get to where this starts to become standard of practice, not the exception, not you have to be lucky, but everybody gets this. This is the standard. You can expect it, you don't have to worry about it. So in my view, the most effective mechanism is talking to members of the public like you and getting you to understand what you're not getting so you can demand it. And the public actually has quite a bit of power in this regard. I think the public feels disempowered. But public demand and public pressure does change what healthcare systems provide, does change policy. This is why I'm here talking to you, because you are the power that can make the changes that we need to see happen. This was an ad that was done by a Madison Avenue advertising firm. When you're living with a serious illness, quality of life counts. These ads were done by the American Cancer Society in New York. They spent several $1 million on this ad campaign. And you can see the picture on the left. It said cancer in black font, and then a purple vertical comes in and says dancer. And the text says, palliative care sees the person beyond the disease. It gives the patient control. It brings specialists together with the patient's regular doctors and nurses in a team-based approach to pain, other symptoms, by providing an added level of support, an added layer of support. The ad on the right says chemotherapy, and the letters are crossed out to say mother. The third ad in the series is a kid on a swing in a playground. It says stage 4, and it crosses out the ST, age 4. And the fourth ad in the series is a father and his daughter outside, and it says radiation, and it's crossed out and it says dad. The message being there is a person living with that disease, and that person and the family around them need just as expert attention as the disease needs. Not one or the other, but both. And that's the end of my remarks. Thank you very much.